I'd like to extend a very warm welcome to all of you to the second Emergency Medicine scientific session at ICON 2022. I am Dr. Afsa Khan, Chief Resident Emergency Medicine, and along with me I have Dr. Adil Khatri, who is the Residency Program Director at Indus Hospital Department of Emergency Medicine. We'll be moderators for the day, and we hope that in this 2-hour journey, you'll be able to explore the horizon of data in developing intelligent pathways to improve patient care in low resource settings. Let's begin with the name of Allah.
والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.
Jazakallah. Moving on, we are joined by esteemed speakers who are pioneers in this field, and we hope to have an eye-opening experience as regards data and its utility here in Pakistan. I would now like to welcome Dr. Devin Singh, Dr. Bilal Usmani, Dr. Benjamin Abella, and Dr. Basit Sheikh. Dr. Junaid Razzak shall be chairing the session. So first we have Dr. Devin Singh. Dr. Devin is a practicing pediatric EM physician from the Hospital for Sick Children in Toronto. He attended medical school at the University of Sydney in Australia and completed pediatric residency and emergency medicine subspecialty training at SickKids Hospital. His research focuses on the use of applied machine learning techniques and is a physician lead at Clinical AI and Machine Learning and Data Sciences for the Division of Emergency Medicine in Hospital for Sick Kids. I'd now like to welcome Dr. Devin Singh for his talk, What Data Can Do for Us.
Hi there, my name is Dr. Devin Singh, and I'm a pediatric emergency physician at the Hospital for Sick Children in Toronto, Canada. I'm also the physician lead for clinical artificial intelligence and machine learning, and the co-founder and CEO of Hero AI, an innovative health tech startup company focused on translating AI solutions into the hands of patients and providers. I'm absolutely thrilled and honored to be here today to be talking at ICON 2022. And I want to chat about what I think data can do for us as clinicians and how we can improve the way we deliver care with data. And so first, let's jump into why AI, or what is artificial intelligence? And when I think about artificial intelligence and combining that with data, I think about this idea of mimicking human-like decision-making by leveraging data, training machine learning models, and having then that data be able to feed into our models for the purpose of automating some kind of decision, right? And why do we actually need AI? Well, let's imagine here, like this is an example of a self-driving car. It's a Tesla, and it would be impossible to program this car in like a hard-coded way to drive down all of these different streets, right? It'd be nearly impossible. And a similar thing would be impossible with healthcare, right? Just given the high variability of healthcare data and systems, we wouldn't be able to hard program that. And there's examples of these autonomous types of vehicles, for example, this drone here, that can be leveraged in healthcare. And this is an example where we actually leverage the drone to fly transplanted organs from one hospital to another, allowing us to overcome many of the logistical challenges involved in the transportation of those organs. And so I started to discover, as I dove into machine learning and AI, that machine learning can help us connect the dots amongst all of the different points of healthcare data. It also allows us to navigate that big data maze that's being generated by, our e-health systems that are, generating massive amounts of data. It also allows us to transcend the different healthcare silos that our organizations are divided up into, right? Whether it be between multiple hospitals or between even just different divisions within a single hospital. AI can help us break through those silos and transcend them. And so let's take an example of a project that we're working on at SickKids. This here 8-year-old kiddo, unfortunately has a really hard fall on his arm, and he comes to our emergency department complaining of a lot of wrist pain. And I'll tell you right now, the moment the kid gets there, he knows that he needs an x-ray of his wrist to rule out a fracture. The parent knows and the triage nurse knows. But what ends up happening is that kid comes to our hospital Their data gets plugged into our EHR tool. And then because they're very low acuity, they will wait probably 4 to 6 hours waiting for that x-ray to be done, because they wait for their healthcare provider. When someone like me comes to see them, I say, well, of course, we're going to get an x-ray to rule out a fracture. And then, I need to then free myself up after the x-ray is done, reassess the patient, and then diagnose the fracture if it's there, and then apply a cast, etc. Right? The question was, could we actually begin to add efficiency to this workflow, given the fact that we know from the point of arrival that this kiddo needs to get an x-ray? And could we potentially automate the ordering of that x-ray to speed things up for that family? And so what we did is we took our triage data, things like vital signs, past medical history, age, the reason for the visit. If it was a data point captured at triage, we took it and we plugged it into 3 different types of machine learning models: logistic regression, random forest, and then the deep neural network models we're all hearing about sort of in the media. These are just 3 different types of algorithms, or 3 different types of approaches that we can use to take data and build an automated system. It's an algorithm that lets us sort of classify this patient into either needing an x-ray, yes, or not needing an x-ray, no. And they're just 3 different approaches that we're going to do. And we tried all 3, and what we discovered actually was that all 3 methods work really well at ingesting that triage data and making a downstream prediction on if that kid actually needs a forearm x-ray. And this is a plot called an area under the receiver operating curve plot. It's a fancy name for essentially a plot that's showing us that the model is working really well. It shows us the true positive rate on the vertical axis there, and along the horizontal axis, it's showing us the false positive rate. And of course, we really want to minimize the false positives, right? Like, we don't want to start x-raying kids unnecessarily. And so we can set a model threshold at a spot on this curve that actually ensures that the false positive rate is really, really low. So for example, here, our false positive rate is 0.0004. It's incredibly low. And at that rate, we may actually be able to automate ordering these tests. And then we also discovered that we could do it for many different things, like for ECGs, for urine testing, for testicular ultrasounds, even for complicated things like abdominal ultrasounds. We could make these predictions really early on with our triage data and potentially automate the ordering of that test, which would save, in the case of abdominal ultrasounds, save about 162 minutes of that kiddo's stay in our ED. Really powerful. And so what we realized was, if we were going to minimize the false positives, it means that we might miss a bunch of cases. So we needed an augmented workflow, or sort of a dual-pronged pathway. And so what we built is this sort of streamlined pathway here, where when the triage data is put into our electronic health record system, it can go into our machine learning models. And if the model fires saying to get that x-ray or to get that ultrasound, we could potentially automate that kid towards that test. But if the model doesn't fire, rather than sending them home, we just send that family down the traditional pathway, where they end up waiting in our waiting room, wait for the healthcare provider to assess them first, and then get the test the more traditional way. And what it allows us to do is to minimize the false positives while not having any harm done to a patient when the model doesn't fire, even if they actually needed that test. And so it's this dual-pronged augmented pathway for deploying machine learning models into healthcare. The second type of algorithms I want to talk about are algorithms that are using image data. And we have this struggle in pediatric medicine, particularly in the emergency department, where it is basically nearly impossible to use a traditional fundoscope and to look into a kid's pupil to assess for raised pressure or papilledema. And this is something we need to do when kids come in with headaches, right? We want to assess, is it possible that their headache is caused by a brain tumor or some sort of mass inside of their head? And one of the signs we look for is this thing called papilledema. But when you look at the literature, we can see we are terrible at actually performing fundoscopy on children. These are all different studies that are telling us we're terrible at doing it. And so we wanted a better way. And what we discovered is that point of care ultrasound, which is the act of putting an ultrasound probe at the bedside on a kiddo's eye, can actually give us really great views of the back of the eye. Even if their eye's closed or they're kind of fussing around, you can get that probe on their eye and you get really nice views here. And for example, this is a normal eye where you can see the back of the eye is nice and smooth. But this here is an eye where there's increased pressure in the brain caused by a brain tumor or some sort of mass lesion in the head. And you see that bump here represents that increased pressure. And so we wanted to combine these images with AI to try and automate the detection of the papilledema on these ultrasound images. And so we took the ultrasound images of a bunch of normal kids and a bunch of kids that unfortunately had this raised pressure problem, and we fed it into deep neural network models that were able to produce incredible results with great accuracy. So for example, here again is another area under the receiver operator curve, and you can see that the curve is performing really well. And here on the right-hand side, we've actually got a heat map where the model is telling us in red where it's most concerned about the image. And you can see it's highlighting the papilledema, the bump at the back of the eye. That's this little bump here. It's highlighting that. And with these two types of technologies combined, the point-of-care ultrasound tool, which is far less expensive than it used to be, quite portable now and even handheld. You could get out to many different community or remote providers. Combining that with an automated AI that can look at the images and detect if that abnormality is there really starts to break down the barriers on how we can translate our expertise out to different community providers. Right? Where they can use an ultrasound machine, put it onto a kiddo's eye, and detect these red flag findings and better understand when they should send kids to an emergency department for head CT scans versus when they should watch and wait. Really powerful stuff. But lastly, it's really important to think through machine learning models and this concern for bias. And we know that our healthcare data is filled with many different forms of bias. And there's lots of studies out there that show that that's true and that algorithms will actually learn the bias in our data, right? And this isn't just a healthcare problem. Amazon, for example, had a model that they were using to help automate recruitment of potential candidates, and it was favoring men instead of women. And it was terrible, and they had to get rid of it, right? Even our smart speakers like Google, Amazon, again, there's a significant bias based on the accent of the person speaking, right? And if you don't speak, perfect English without an accent, you can see here the error rates of these technologies is far worse. And essentially, it's introducing this bias, right, into those solutions. Here's an example of different, facial recognition technologies, and that if you were female and had a darker skin pigment, you had many more error rates compared to other people, right? And again, another bias being introduced by massive companies that are expert with AI. And I bring this up, not trying to sort of bad talk these companies, but just to say that bias is real. It's a hard problem to solve. And in healthcare, we need to think about these types of biases. And when we explore these machine learning projects, we need to have multidisciplinary teams that are thinking about EDI or equity, diversity, and inclusivity in how we construct these projects and how we tackle bias. Because when we start to do our error assessments on our own algorithms that we build in healthcare, there will certainly be some sort of subpopulation that is underrepresented in our data and that will have a high error rate. And it's just going to happen. It doesn't mean we should abandon AI, but it means we need to anticipate it's going to happen and then think through how are we going to mitigate this problem. And I strongly believe that we can leverage AI for good. The act of looking at our data, training these machine learning models, doing these bias assessments will allow us to uncover systematic biases in our healthcare system that we can start to tackle and solve in many different ways, which will really improve the way we deliver care to many of our patients. The last thing to think through, though, is when you build your solutions, if they require, particular types of hardware in order to access your solution, that's going to create another bias and another health gap, right? And so that model that I described about training these triage models, we actually want to translate them to patients' homes. And we want to use wearable data and leverage those signals in the home to make predictions even earlier. But if my patients need to pay this much money to access the technology, I'm going to create a bias and a healthcare gap that I want to avoid, right? Even things like access to internet. In Canada, we have these pockets of like highly populated areas that have great internet access, but there are people who live in these northern regions with inadequate access to broadband internet or high-speed internet. And what's going to happen is if I build these solutions that depends on internet connectivity, folks in the northern parts of my province aren't going to have, great access, and they're going to experience this phenomenon where their healthcare is literally loading because they don't have the access through the internet connectivity. It's absolutely something we need to avoid, and we need to advocate for foundational solutions to be in place so we can leverage AI and machine learning on our large sets of healthcare data. AI has to be for everyone. It's challenging to think that way, but when you start your projects early with that in mind, you'll see the solutions really come to light. Again, a real pleasure to be here. I tried to throw a lot into such a short period of time, but please do feel free to contact me at either of these email addresses. I'd love to meet with all of you, so please reach out anytime. Thank you for the opportunity to talk here today. It was an absolute pleasure.
Thank you, Dr. Singh, for a wonderful eye-opening talk on the importance of data in our lives. Next, we have Dr. Bilal Ahmed Usmani, who is a PhD in mathematical biology from the University of Glasgow. He has a special interest in infectious disease epidemiology and has rich experience in applications of modeling techniques on the analysis of big data. Dr. Bilal is currently working as faculty at Khan University Hospital and has been a part of multiple curriculum design and is playing a substantial role in the research and capacity building of data science professionals from the initiative. I would now like to invite Dr. Bilal Ahmed Usmani for a mathematician's perspective on ED data.
Yeah, ma'am. So am I audible? Hello,
Yes, Dr.
am I
Bilal,
audible?
you are audible, Dr. Bilal.
Okay, thank you very much. So I'm trying to thank you very much for inviting me and giving me such an honor to talk at this prestigious opportunity, prestigious occasion. So let me share my screen. I hope that my screen is visible to all. Is it right? So is my screen visible to all? Hello, am I audible?
Yes, Dr. Bilal, you are audible.
And my screen is visible?
Yes, it's visible.
Okay, thank you very much. Okay, before any further delay, so I'm a mathematical modeler by background, and I've done my PhD in mathematical epidemiology. It's not biology, by the way. So we are looking at the clinical data and the mathematician by a mathematical modeler's perspective. And so being an epidemiologist, I look into mostly into public health. So my talk will be basically centered upon the clinical data that has some implication to the public health or the related areas. So let's start. I'm a section head of epidemiology in biostatistics section at CHS department, AKU. So why do we need data modeling? This is the first question. Because it has a lot of maths, and we go to further studies. It has to do with the AI and different stochastic or state space models that are quite hard to comprehend. And so why we need that? So one thing is, in the absence of data or limited sparse data, whenever we don't have data, so the modeling is very helpful to see the trends and patterns of disease spread. So although you don't have much data, we can still say a lot about the trends and the underlying dynamics just by looking at the model. So in addition to being interesting on its own, the healthcare and clinical data provides an additional layer of reliable information, very important information. They are gauging the situation at the very bare bones, and it's important for modeling and projections. So models could help us develop a deeper understanding of disease and establish a hypothesis for pathogenesis, or improve our understanding of treatment methods. We can use modeling for that, and to fulfill the critical needs of public health officials and policymakers, and to minimize the healthcare burden by predicting the possible threats beforehand. So this is why we need the modeling. So what are disease models? So they are mathematical and computational frameworks. We need to have some programming for that, to use some software to run our model. So model is structure, simulation is running that structure by using it some information, by giving it, by putting it some values. So it could be useful in interpreting the transmission behavior of diseases, say for example COVID-19. In any sort of environment, we can explore what if scenarios, and we can do what would happen if this condition is not met, what would happen if this would happen, and so on and so forth. So on the right you can see the basic SIR model. This is susceptible, infected, recovered model. I don't have much time to talk about that. Just to give you an example, so this is being done for flu, and these are some initial parameters, and these are some model output. So this is an idea of what a model is. So this is a typical structure of a mathematical model. So you have a physical problem, you identify important variables, you apply relevant physical laws. Of course, transmission rate shouldn't be negative. You make reasonable assumptions and approximations, and usually you have an equation or a mathematical framework, and then you apply applicable solution techniques, apply some conditions if there are. Say for example, the number of COVID cases in Pakistan cannot be more than the population of people in Pakistan. So this is some sort of boundary condition which is there, and then we will look at the solution of the problem. There are certain things to notice though. So if we have good data, we have good projections, usually rely on realistic assumption. In case of lack of empirical data, we need to assume a lot sometimes in the model. So the best thing is, and this is an excellent way to investigate the what if scenario. Say for example, a plane simulator, it would help us learn the new pilots how to tackle the issues while handling an aircraft, rather than actually doing it and crashing it, and there will be a lot of catastrophic situations. So it will be a cold test rather than doing it in the field. So I was a fond of Tom and Jerry, and I used to I'm still fond of it. So this is a cartoon in which the Woody Woodpecker, there was a child of a woodpecker. Oh God, my cartoons. It's a woodpecker. So a child of that, actually he did some sort of maths by calculating the angle so that the end of the pole will exactly fall to the cat's head, which is poor Tom. So this is one of my inspiration to predict things, how it did so well. But predictions are not set in stone. This is not like it in the real world. They are subjected to changes through errors and uncertainties in order to improve the overall performance. So we need to do it again and again. We need to look for more empirical evidence. We need to look for more reliable data, and then see how could we make it better. So let me take through the journey immediately after the COVID outbreak. So in last year in Feb, I tried to model the Hubei outbreak projections and see what would happen if the same parameters or the rate of spread was same. So immediately after that, by the end of February, and then by the beginning of March, the COVID come to Pakistan, and we have our first lockdown after 23rd of March. So there are certain questions which were asked by the government of Singh, by NED University. I was a part of that university as well, and I was as a consultant at AKU. So what is the healthcare burden of COVID-19? What is the rate of spread in the population? How many beds and ventilators are needed? These questions emerged immediately after that, and a lot more. So what I did is, so I don't have much information. So usually the prevalence is known. हमारे पास we have the number of infected people that are being traced in the hospital or somewhere. We can trace them better, but usually the rate of transmission is unknown. So that was a huge problem. In addition to that, we don't have any information about the incubation period, if there is any, say 5 days or 7 days. We don't have. Imagine beginning of the COVID situation. So what I did is that I use a SIR model for multiple transmission scenarios. The number of days of hospitalization were estimated by the model. So I used the number, so the rate of hospitalization for that, and the number of days of ICU were calculated based on the gamma distribution. So how many days a patient will spend, depending upon the conditions, or if not given any condition, what would be the optimum or the scenario for the bed availability. So this is an example. I don't want to put everyone into that modeling, hardcore modeling, but this is the cases detected as proportion of true. So I thought that the true cases are 10 times than what is being detected right now, because not everyone was going for testing. There was a taboo. People think that if they got COVID, they will die, and there are not testing facilities at all in the beginning. So what is the percentage of critical patients? What is the number of exposure per patient? We use some sort of data. I did some sort of calculation, and then the transmission rate is being estimated. So these are some worst case scenarios, and this is the number which everyone wants. And this is quite hard for me to give that number on the basis of such sort of assumptions, especially to the government of Singh. This is another example. So what is happening over here? So these are the assumption in case of no information. What I did is that so worst case is 5% transmission rate. After some time, at that time it was 35%, but it was very because of the sparsity of the data at the very beginning, the transmission rate was fluctuating a lot. So I took the mean and then see, and what happened if transmission rate was 2 to 3%. What is the effect of lockdown, and what is the community sensitization? Say, for example, if there are a lot of deaths, so I assume that mobility patterns will decrease, and that would affect the transmission. Similarly, how much of the population would be infected of especially say of Karachi or of Sindh by the end of the epidemic and the total course of pandemic. So these are some assumptions I have. Say, for example, 25% or 50%, and I also did for 10%, 12%, and things like that. So there are certain type of cases which we build. So what happened if 50% population was infected when the transmission rate was 10%? What happened if 50% population was infected when we have variable transmission rate? So I took the running means of the transmission. So the transmission is varying, so as the transmission rate. So the more the transmission rate, more the deaths, and then actually it puts us towards the other end of community sensitization. So there were a lot of assumptions, but just to give a gist of what was happening at the time. So these are some results that 5% of number of hospitalization and requirement for ICU in Sindh. I assume that 5% of all infected cases result in hospitalization, and 1 out of every 200 require critical care. So these are some scenarios I built for number of patients of ICU in a given day. So there were some projection for. So this is an example for Gilgit-Baltistan, and these are the scenarios, worst case scenario, lockdown and everything, and how it reacts. So these are just some projections that were I think helpful. This is an example for COVID healthcare burden estimate. So we need some sort of demographic data, we need some sort of healthcare capacity data, we need positive cases, hospitalization, and critical yield cases. So this is all from the clinic side. And then these are the model parameterization. So the model is being parameterized on the basis of this data. So the parameters are there, but the transmission for leishmaniasis is different than the transmission of COVID, and it's different than the transmission of TB, and it's different than the transmission of hepatitis C. So it all depends upon the data, how to parameterize that. We run our model, and then we get some sort of information. We got asymptomatic cases, preclinical infections, critical infections, recoveries from asymptomatic and symptomatic infections. And then at the end, we also get district-wise hospitalized and critical cases. So this is what we get by using the data. So clinical data is not, in this particular study, or especially in this presentation, it's not a standalone thing, but I use it from the different, in addition to the clinical and in addition to the public health and the demographic data. Now, so these were some projection. Recently, the paper was published, and there was a projection, and for the best empirical. So I did 5 times. So first, at the very beginning, I used the parameter values for the Hubei, and I say what happened. That projection was done on 26th of March. So 21st of March, sorry. So 21st of March, what would happen? I don't know. I have any information, and I used the Hubei, and that predicted the peak on 8 May. But the number of infected are horrible. This is 10 to the power 4. And it is per day. But by using more and more empirical evidence on 31st of May, I was able to predict the peak better. So that was on 10th of July, and it occurred somehow around the first end of June or 1st of July. So, and these are the events on the right which are being considered for the projections, uh, especially in these type of cases. Um, this is also so I got the data for the infected population and the data, and I assume it's again at the very beginning. It's 30th June 2020. So what I did is I assume that actual infected are reported infected times of 10, 5 times because of not actively testing, encouraged to test, or they're not able, they don't want to get tested, and 5 because of there is no data or there is no facility over there. So these are some projections. If mandates were being used, say if 25% population started using mask. Okay, it's flipped. 50% is over there and 25 is over here. So it's a bit flipped up. So if 25% is the black line represents the 25%. And what would happen if 50% of population started using masks? So this is what we get for the cases, and this is also done for the second wave, because sin, what was the contribution of sin in the second wave for COVID deaths and for COVID cases. So it turns out that in the second wave, in the first wave, sin was the major determinant in addition to Punjab. But in the second wave, Punjab turns out to be the main contributor, as you can see in this diagram for the cases, Sindh and Punjab, and you can see that that's hiring. So these are two main which are actually contributing. So this is one of the projections I did for the third wave for the government of Sindh. This is also the town-wise breakup of cases in Karachi during 2020. What I did is that I took the data and the spatial information. So from which residence or from which the town level the information was coming, and this helped the strategy of the smart lockdowns. As you can see that in Gulshan town during 2020, there were a lot more cases than compared to other, and then followed by Sadr town. So this is the sort of analysis we did, and we also use a model to predict what would happen next. So that's all for my presentation. There are some discussion points I would like to add. So clinical data provides us a lot of information about the total situation of spread and persistence in the population. Outbreaks and epidemics are major and common event in Pakistan. We have seasons of dengue, we have typhoid, and then diarrhea, and then for hepatitis C and we usually have sepsis. In hospitals. So there are a certain sort of outbreaks and epidemics. They are quite common, and unfortunately there is a limited capacity. So people are using techniques that are mostly statistical, and then the people are using techniques that are mostly computer based, AI based. So I also applied some artificial neural networks and those type of techniques, but I think the modeling has its own standing. There is a limited capacity. There are not very much people who actually are doing mathematical modeling for this type of data analysis, which has a lot of potential. And it could be combined with AI for developing intelligent decision support system. Last year, we won a grant from World Bank, and we developed an intelligent decision support system by using AI techniques, amalgamating the AI techniques and the modeling techniques to providing a framework of what to do and in what areas, and smart lockdowns, and what would be the burden in the next couple of days to predict that. Genetic data. So just a point that if for the clinical data, if we do some sort of genetic data analysis, phylogenesis or something, they are also very helpful for this sort of analysis. So yeah, regarding the time given, I think this is the best I could do. Thank you very much.
Thank you, Dr. Bilal, for the wonderful talk. Next, we have Dr. Benjamin Abella. Dr. Abella is an emergency medicine practitioner, internist, and a researcher. He is a professor and vice chair of research at University of Pennsylvania Department of Emergency Medicine. He has participated in developing international CPR guidelines and is a director of Center of Resuscitation Science at University of Pennsylvania. Dr. Abella has published over 200 scholarly works, reviews, and monographs in numerous professional journals including NEJM, JAMA, and Circulation, as well as textbook chapters on cardiac arrest and resuscitation. He is a fellow of European Resuscitation Council and serves as a co-chair of the AHA Resuscitation Science Symposium. So let's hear Dr. Benjamin Abella on identifying quality data and its potential.
My name is Dr. Benjamin Abella. I'm a physician at the University of Pennsylvania, where I'm vice chair for research, and I lead a number of research teams involved in clinical and translational emergency care investigations. The topic that I'm going to be sharing with you today, consistent with this session, is talking about big data and data technology, and specifically for its use in emergency medicine and how we have used it and viewed it as a tool in emergency medicine clinical work. And hopefully some of our perspectives can be useful for work in Pakistan and other countries. As I think you'll see, a number of the examples I will use generally are applicable, especially to low resource countries or more global populations, and allow for generalizability and going to scale. So hopefully this will all be useful information. And I'm going to do this in a format of essentially giving three examples, three stories to tell, as it were. These are three use cases in emergency medicine from University of Pennsylvania, where I work, from our Department of Emergency Medicine. One is how we have used big data for cardiac arrest research, and both not just research, but quality assurance work as well. Another example I will go through is bedside ultrasonography. Bedside ultrasound, as I'm sure you all know, point of care ultrasound has become a very big growth area with a lot of potential, and we'll be sharing some examples for that. And then I will also talk a little bit about work we've done in COVID-19 patient care, not really using big data per se, but using data technology. I think this will be of interest as COVID continues, unfortunately, to plague all of us. And it shows a way forward, not just for COVID, but for broader emergency medical support of our patients using technology. Now, first, to give a little bit of context, I work at an entity called Penn Medicine, that is the health system for the University of Pennsylvania. It's a 7-hospital network in the United States on the East Coast in the area of Philadelphia and the state of Pennsylvania. It comprises 7 hospitals. One region of Philadelphia, known as West Philadelphia, has 3 main of our flagship hospitals, and I show you photographs here of our 3 flagship hospitals. We serve a diverse community. In many ways, a resource-limited community, because we serve minority populations that are generally more poor, more socioeconomically deprived. And so we often have to come up with solutions that plug the gaps in socioeconomics and medical follow-up and medical insurance and so forth. We're proud that Penn was actually the first medical school in the United States, so we have a very large teaching and research component in our health system here in Philadelphia. Now, the first example I want to share with you is the use of big data in cardiac arrest research. Now, I imagine this audience hails from a variety of different clinical perspectives, so a little bit of background. Cardiac arrest, of course, is when the heart stops suddenly. It's a leading cause of death around the world, often provoked by underlying coronary disease. Blockages in coronary arteries lead to sometimes heart attacks, which can lead to scar tissue in the heart, which can subsequently sometimes cause fatal heart arrhythmias. That is one pathway for cardiac arrest. There are certainly other causes as well. And cardiac arrest is a notoriously challenging topic to study for a variety of reasons. Of course, it's unexpected, so it's hard to prospectively enroll and study patients with cardiac arrest. Also, it's challenging because most people die from cardiac arrest. So to study survivors requires a large net, a large data set really to work with. And so one of the things that's been developed in a number of countries, the United States is one such example, are large data registries to support cardiac arrest research. And these are two publications from our teams at University of Pennsylvania using a registry known as CARES, the Cardiac Arrest Registry to Enhance Survival. This is a long-standing, very large registry in the United States that, by the way, the technology for this has now been generalized and used in other areas. There's an entity called PAROS, the Pan-Asian Resuscitation Outcomes Study, that I believe Pakistan may be a member of. I know Turkey is, that would allow participation in a larger data source as well. If you want to check out CARES, I've put the website there. CARES was designed originally as a QA database, and a lot of large data repositories, I suppose in a way the emergency medical, electronic medical record itself, was really for clinical care or QA, but it often can be co-opted for research. And in this case, the CARES registry has several 100,000 cases of cardiac arrest in it from around the country. And to give you a little bit of a sense of CARES, they have really grown exponentially. There's a map of the United States showing coverage. The blue are the covered states, so large regions are covered in CARES, and hundreds of thousands of cases. Now, this is a voluntary database. And one important thing to think about when thinking about large data registries or data projects are whether it's a mandatory or voluntary. Of course, if you make it mandatory, you get better data capture, but that often requires political, governmental, and other support to make it so. CARES went for a voluntary approach, which is less expensive. Of course, the quality of the data sometimes is more variable because you can't be guaranteed that all cases of cardiac arrest in this instance are uploaded. Nonetheless, CARES has worked with pre-hospital providers or emergency medical services, EMS providers, to upload data on cardiac arrest, CPR provision, shocks given, which is defibrillation for heart arrhythmias, outcomes, survival or not, and then it's linked to hospital outcomes. So it allows for evaluation of outcomes, processes of care, and it's been used for both research and QA purposes around the United States and for investigations such as the ones we've done. And I wanted to show you a recent example. This is not work from my team, but work from colleagues in Missouri, Paul Chan and others, looking at CARES, using CARES to look at cardiac arrest survival during the corona pandemic. COVID-19 pandemic. And so I think this is a nice example of how data registries, not only do they allow for investigations, but they allow for setting a baseline so that if things change, a new pandemic, new protocols, new interventions put in at the population level, you can then look for changes over time in this baseline of data. And in this study, what they showed, and I'm not going to walk through the data, it's really just an example, is that looking at before and after COVID-19, they found that survival, shown here, ROSC, ROSC, or return of spontaneous circulation, that's initial survival, fell from cardiac arrest during COVID-19. And one might wonder, was it due to the COVID illness or other problems? And it seems they've come up with a mechanism for this by studying the CARES data, that many more people had termination of resuscitation earlier. And that's that bottom set. So what this means is they found that probably due to fears of infection, fears of transporting COVID patients, many more patients had their CPR and other efforts stopped in the field, leading to a higher risk of death. And so this, of course, leads to many other questions, whether the termination was appropriate, whether there's ways to manage this better to improve survival. So these are some of the ways large data registries in cardiac arrest have been and can be used. Now, could this be useful in Pakistan? Well, indeed, one of the participants in this conference, Junaid Razzak, a colleague in New York State and New York City, has looked at cardiac arrest in Pakistan, not using the CARES registry, because of course the infrastructure is not quite there in Pakistan, but looking at other techniques to capture cardiac arrest data. And he used this and his team for traumatic cardiac arrest. And, there may be important value in building data registries around cardiac arrest, a major public health issue in countries like Pakistan, because it may, of course, be interesting to know how is access to AEDs, defibrillators that are in public spheres such as train stations or shopping areas and such? Are they available, and are people using them? And how is EMS resources allocated in a country like Pakistan? These are important questions that you need broad data for. So I applaud the Pakistani researchers who are conducting these sorts of studies. Now, to go to another example, we also have been, of course, plagued with COVID and trying very hard to improve COVID outcomes. And one of the major problems in the United States, and I'm sure around the world, is the emergency medicine resources are overwhelmed with COVID. And many patients are sent home because they're just not sick enough to be in the hospital, and there's no room in the hospital. But some of them deteriorate at home, and we need to have a better monitoring system for that, and a low-cost monitoring system. And so this is where data from the EMR was then translated into technology for an app. And this is the COVID Watch app developed by investigators at University of Pennsylvania in our department, where the basic idea here is a patient could show up in the ER with COVID. Their ambulatory oxygenation was fine. They looked okay. Certainly they were a little sick. Maybe they have a fever or feel a little unwell, but the decision was made to send them home. Well, through the electronic medical record, they could be enrolled in an automated, essentially a bot, an app that would stay in touch with them every day and ask them two simple questions. Are you feeling better or worse? And then that prompt would then, if they said worse, how is your breathing? And if that prompt said your breathing is worse, then it would prompt a call from a clinician. So if people were feeling okay, no call was required. And this is therefore no resources. It was just the app on their phone, basically serving as a very crude form of artificial intelligence surveillance. And so the nice thing about this is patients didn't need to be part of our medical system. They could be from anywhere. And we could monitor them and follow them over time. So the question, of course, then became, did this improve outcomes? So this was part of a study that we did where thousands of patients were enrolled in this COVID Watch experiment, essentially. And it was found that survival was actually improved. So this is quite remarkable. This is using data technology and showing that it actually improved survival from a deadly disease. So it's quite remarkable. And thousands and thousands of people, only two clinicians, two nurse practitioners were involved in monitoring a patient population of 7,000 patients. So very cost effective. And how did this work? Well, here's the publication if you want to look for it online. Essentially, the mechanism of survival was probably just earlier capture of the patients who worsened. So people didn't get worse at home and then not report for medical care. This app captured them. And so if they said they felt worse, they got back to the emergency room earlier and they got treated earlier. So you see here in the red box, about 3 days earlier, when they were in COVID Watch versus the randomized control group, they received dexamethasone. So earlier management with steroids for those who are more short of breath. Very simple. Earlier care led to better survival. And this is a really exciting example of how we might manage the next pandemic or future major public health concerns, where it doesn't always have to be by a clinician, but it could be by remote monitoring as long as people have smartphones. Now, my third and final example of using data technology to support clinical care and research is in the realm of ultrasound. And I show you here a relatively new innovation. This is the butterfly ultrasound technology. And full disclosure, I have no stock, no relationship whatsoever with Butterfly. I am a user, but there's no financial conflicts between me and this company. And this device is cleared for use clinically in the United States. So this is a handheld ultrasound device that has the unique innovation of being able to hook up to a smartphone. So as opposed to having a large, expensive machine, you can just have this in your pocket and you can go anywhere with it and upload images via the smartphone. So it really is a potential for a massive change, and it could really find its use in resource-limited countries or environments where CAT scans and other more expensive capital equipment may not be available. This essentially can be as readily available as a stethoscope. Well, one of the exciting things, and this is work done by colleagues at Penn and my department, Nova Panabianco, one of my mentees who is very involved in ultrasound research. She and others demonstrated that not only can you do this easily in resource-limited areas, but you can do it via telementored, telemetry mentored approaches. What do I mean by this? Well, performance of ultrasound is a skill. Skills are variable and maybe training is variable, but you can via a webcam and audio contact actually coach someone through to perform an ultrasound around the world in far-flung locations. And of course, this creates enormous opportunities for field operatives who are using ultrasound, who may not be highly skilled, to still perform point-of-care ultrasound for diagnostic purposes. So this could be used in the community, in resource-limited community clinics. This could be used in a variety of settings. And for very common and important things like pregnancy ultrasounds to evaluate for ectopic pregnancy, are there complications, to look for blood clots in the legs, and so on and so forth. Very useful in trauma evaluations. Well, what is the real power here? It has to do with big data and machine learning. So the Butterfly system is part of something called the Butterfly Cloud, and this is through Amazon Web Services. All of the image data are uploaded to the cloud and are processed. And what Butterfly envisions is a world in which thousands and thousands and thousands of ultrasound images will be processed through highly parallel systems to then do machine learning for ultrasound interpretation. So that not only might you need to cut out the skilled operator via telementoring, you might even need to cut out the skilled reader if machines over time can learn to do this. And there's a lot of active work right now in artificial intelligence and machine learning for ultrasound, which I think will ultimately be a massive game changer for global health. So I think in summary, in emergency medicine, there are many examples of how big data and data infrastructure and technology infrastructure will change how we practice. So in emergency medicine, we look forward to the day where artificial intelligence will grow and support our practice around the world, and could certainly support practice in Pakistan. If you want a nice book that peers into the future, Eric Topol is a cardiologist in the United States. He wrote this book about the role of what he called deep medicine or deep learning in medicine. And there are several emerging medicine examples in this book. To just cite some of them, I would not be surprised if in the near future we will see more and more emergency medical record plugins. That is to say, if you're using an electronic medical record, it could certainly link to AI resources that could guide diagnosis using the data that is in the system already. Certainly, I think it's a tough time in the future to be a radiologist because a lot of radiographic work may become automated through AI approaches. Good for patients, perhaps bad for the workforce of radiology, although I'm sure there will still be use for overreads by humans. But those algorithms keep getting better and better. And then I think in emergency medicine, a really key thing would be early warning systems for clinical deterioration. We worry a lot about patients who are getting sicker in our crowded emergency rooms or in our waiting rooms. And by monitoring them and using predictive models through deep learning, we may be able to better catch folks before they get too sick and before we get into trouble. And so these are just some ideas of where the field is going in the United States. And I just wanted to thank some members of my research team. And I show you here some of them doing a public CPR training event in Philadelphia. We really believe in getting out into the community to do some of our work. And in cardiac arrest, of course, public training in CPR is essential. And I hope maybe that's one area where Pakistan can use some data, large data surveys to look at the rates of CPR provision to save lives in Pakistan as well. Thank you very much. And I look forward to the oncoming panel discussion.
Thank you, Dr. Benjamin. For our next talk, we have Dr. Basit Sheikh. Dr. Basit has done PhD from Imperial College, London University. He worked with Siemens Medical for over 15 years in design, development, and deployment of MRI system. He is involved in academia for over 14 years, trying to bridge the gap between industry and university. He is a visiting faculty and member of Board of Studies, Computer Science Department, and Institute of Business Administration, Karachi. He also heads Mercurial Heads, our digital mastermind, our digital transformation company. So I would now like to invite Dr. Basit for his talk, Stakeholders' Perspective, What Transformation Looks Like for Patients and Administration.
Assalamu alaikum. Can you hear me?
Walaikum Assalam ji, Dr. Basit.
And can you see me? Can you see my slides now?
Yes, Dr. Basit.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. And thank you very much, Indus Hospital, for inviting me to give this presentation. It's an honor. And thank you very much for the introduction. Compared to the previous three speakers, I sit on the other side of the river. And my job is actually to take the technology and bring it into practical use where people can benefit. And that's not just in terms of from a medical sense, but also in my other work in terms of the application of technology for process automations. So in terms of the stakeholders' perspective, what does a transformation look like for patients and administration? The previous speakers have discussed in quite some detail the ingress of artificial intelligence in healthcare. And this quote is quite important because the AI application is expanding into areas that were previously thought to be only the province of human experts. And one of the most important aspects of AI is that it's what we in technologists refer to as the second age of machines. Because now what AI is doing is actually ingressing into our cognitive abilities. So it's actually, in the past, the age of machines entered into the power end. So we had cars, we had airlines, we had electricity, we had motors. But now AI is coming into our cognitive abilities. So it's actually taking a role in where the human mind had its exclusive role. And so it's actually quite important to discuss artificial intelligence beyond the hype. So what does an AI transformation actually look like, say, in an emergency department? And what I'm trying to do here is to take the audience, the whole range of doctors and even medical practitioners, and even those who form part of the medical administration, that exactly how it will transform the way your departments and you will work. So consider the emergency department where timely delivery of quality healthcare is of the essence. Okay, so what actually happens there? Just to break it down into morsels that matter for us, the biodata, the patient history, examination, information, investigations, all that data, together with that medical practitioner leads to a diagnosis, and that forms part of the electronic medical record. And as this process continues, you have a whole host of electronic medical records being generated, which encapsulate the whole range of data across the spectrum of patients. And it is this back-end data that is incorporated within the mind of the medical practitioner that helps and informs us that diagnosis. So let's transport back to the emergency department. The patient comes, history is taken, and the doctor is typing in all the necessary data, the symptoms, all the data required from the patient. And then he decides on a possible diagnosis and moves ahead with corrective action in terms of tests. Now imagine what's actually happening on the electronic tab or the iPad or whatever that he's typing in. Suppose he says he has right flank pain. The tab then types up the possible diseases. What is actually happening here? When the doctor types in right flank pain and gallbladder disease or liver disease, gastrointestinal disease is actually being displayed by the tab. As the doctor types in those words, the software at the back end, call it the AI, has been trained using natural language processing, using all the cases that have occurred in the emergency department where right flank pain and similar terms have been used. So in every case where a patient has gone into the emergency department and all his medical records have been typed in, using natural language processing, those statements have been taken in. Then subsequent to that, whatever diagnosis was made, that diagnosis has been trained using the ICD-10 labels against the existing data corpus. So therefore, when the medical practitioner types in right flank pain, the options being delivered by the tab are all those options that the process, the AI has been trained on for all the thousands and thousands of cases that have occurred in the past. And so what that means is that the medical practitioner has access to him on the tab all the thousands of cases that have occurred in the past. And so as the patient types, so the NLP cognitive engine at the back end interprets and correlates against possible diagnosis in real time. So in a practical sense, the medical practitioner has at his fingertips the minds and the diagnosis of all the other medical practitioners. And that is being highlighted via the suggestions being given to the medical practitioner as he processes the information available to him. So it's quite important to understand here that the difference is that in the absence of this, the medical practitioner will only be using all the data that he has learned and he has studied and what is accessible to him at that point in time, what he can extract from his memory. With the tab and with the AI and the natural language processing, what's happening is all the data in the past has already been processed using the notes that the physicians had used, and they've been correlated against ICD-10 labels, and therefore he has access to the minds of all the previous cases that have occurred. So it means that the time is saved in diagnosis because the obvious diagnosis is presented to him, and if there are nuances, it's presented to him, and if there are nuances that he is sensing, he obviously has the prerogative to incorporate that in terms of his diagnosis. Now, the important point is that this loop is existing for him for all the electronic medical records, all the cases that have occurred in the past. So the electronic medical records are within the AI and they encompass the combined EHRs. So what's important to understand here is that all the learning, be that positive or negative, that have occurred in the previous cases is now presented, is encompassed in that AI and is available to the doctor whilst he's doing that diagnosis. So to answer the original question, what does a transformation look like for patients and administration? From a patient's perspective, the quality medical care is provided. And from the patient perspective, that is being provided because the care is being supported by previous records of patients as processed by AI. And therefore, timely care is provided with the best possible diagnosis made given the symptoms. And therefore, from a patient's primary perspective, he could not ask for more. He should not be asking for more because it effectively means all the thousands of doctors who have looked at similar cases through the AI are helping that current medical practitioner make that judgment. And so the quality medical healthcare is provided. There's a secondary perspective which is quite important. And being a practitioner of technology, the user journeys, as we call them, are very important. If the user journey isn't suitable, then the user doesn't use it. And so therefore, from the patient's perspective, the patient isn't interacting with AI, the patient isn't interacting with a tab. The patient is interacting with a human being, is interacting with a medical practitioner who at his fingertips has access to all the possible cases as interpreted by the AI. The patient is also assured that his medical care is provided by human intervention. It's not a bot. And naturally, the personality, the data is protected. So that's from a patient perspective. Beyond the hype, what does the transformation look like for administration? And my previous speakers have talked at length at the applications of AI for a whole host of cases. I would put it to you that from an administration perspective, the transformation looks the same. That is, AI has provided the necessary support to aid the provision of quality healthcare in a timely fashion, because that is the primary responsibility of the administration. But in the back end, there's a difference. And it remains at the administration's primary perspective, but carries a certain imperative. When that medical practitioner is typing in the data, the AI is releasing the physician from the mental load of making consistent, repetitive decisions. So it's actually releasing his mind and not tiring him out. It supports the physician in making physician-like judgments when physician judgments are limited for various reasons. And therefore, the AI is complementing, not competing with the medical practitioner's expertise. And this is a very fundamental point to understand. If the AI is complementing and not competing with medical practitioners' expertise, then from an administrative perspective, this is what I call that the transformation must mean an AI imperative for them. They must carry for themselves that the AI is an imperative to be introduced within their organization. What is the meaning of this AI imperative? It means that there is organizational commitment to support AI-based support to the medical practitioner. Why this is important? Because at least in the region where I work in, it is up to the medical practitioners or the technologists to inform the organization of how AI will help them. And this will take centuries for this to come into our society. The previous speakers has very emphatically shown how AI can actually help diagnosis and actually improve the quality of diagnosis and quality of care produced. So therefore, the AI imperative means that there's an organizational commitment to support AI-based support, to provide AI support to the medical practitioner. Now, what I mean by this is the encapsulation of all the medical records must exist in electronic form. And the key take-home message is this, that the data must exist in electronic form. It is no good for an organization to have paper records, because with paper records, you cannot apply AI. The first port of call will be to convert that into electronic form. The second part of it is to have incorporated within the organizations software developers with data scientists who then work with the data and the medical practitioner in order to train on the body of corpus data to establish the learning algorithm and make it available to medical practitioners. So what I'm saying here is that it is the organization's responsibility to restructure such that the medical practitioner is working hand in hand with data scientists who are working with all the electronic data in order to develop the necessary applications so that in the emergency department, as an example, as the medical practitioner types in the data, he is provided with all the relevant possible diagnosis. And so there's a restructuring. The IT department just provides the electronic support. The medical support must be seen as a fusion between the medical doctor and the data scientists who work together to develop the apps. So therefore, it's not just about the emergency department. It actually is also part of every outpatient clinic. And so therefore, what does a transformation look like for administration? the administration must integrate digital technologies with AI algorithms to support delivery of healthcare. And it's actually very necessary for the administration to reach out to educational institutions that carry that AI background, that carry the data scientists, that actually carry the software developers that can be used to integrate activities with the medical practitioner to develop that. As a final point, what this actually means, any organization, any medical organization that's actually serious about it needs to start looking at something called a chief digital officer, whose role isn't to provide the internet within the hospital. It's not to provide the database for the records. The chief digital officer's responsibility is to employ digital technologies to capture data as an input into AI algorithms to support the delivery of healthcare. And so in conclusion, what does a transformation look like for patients? In real terms, for patients, they will sense that the quality of healthcare provided to them was much better, not knowing whether there was AI in the back or not. All they saw was a medical practitioner with a tab. From an administration perspective, it's a very fundamental change in mindset, where they look at their role is to merge AI technologies and all the necessary infrastructure required for that, so that the AI algorithms are developed to support the delivery of healthcare. Thank you very much, and we'll discuss further, I hope, in the Q&A.
Thank you, Dr. Abdul Basit. Next, we have Dr. Junaid Abdul Razzak. Dr. Junaid Abdul Razzak is a graduate of Aga Khan University. He completed his residency in emergency medicine from Yale New Haven Hospital. He is currently the Vice Chair Research, Department of Emergency Medicine at Weil Cornell Medicine. He has worked at the NIH as a visiting scientist and led NIH Collaborative on Emergency Care Research in low and middle income countries. He has more than 130 peer-reviewed papers on topics ranging from emergency care and vulnerable communities to innovation and technology. Currently, as a part of his focus on global health, he is working with Aga Khan University to establish the Center of Excellence in Trauma and Emergencies. Over his career, Dr. Razzak has served leadership in roles including founding chairman, Department of Emergency Medicine at Aga Khan University, Director of World Health Organization Collaborating Center for Emergency Medicine and Trauma in Eastern Mediterranean region, and founder of EMS for the city of Karachi in Pakistan. He has also held emergency medicine faculty appointments at Yale and Emory universities. Dr. Razzak is the recipient of numerous awards, including Presidential Lifetime Achievement Award from the Global Emergency Medicine Academy, the Award for Outstanding Contribution by the American College of Emergency Physicians, and the Mentorship Award from Johns Hopkins Emergency Medicine Residents. Dr. Junaid Razzak will now give his views on current efforts to improve status quo in Pakistan.
Health and icon for the invitation. It is such a pleasure to be part of this outstanding conference and outstanding group. I'm going to be talking about decision making in emergency medicine. And what I mean by that is, what can physicians working in the emergency department do to improve the outcomes of patients? Now, why emergency medicine? Why emergency department? And those of you who are working here know that every 5 seconds, 6 people die due to emergency diseases globally, every 5 seconds. And 4 of them are in countries such as Pakistan, the low and middle income countries. One of them is a child, and one of them is a victim of injury or trauma. Now, this graph is showing what we all know very well, that the the income of the country determines the burden of emergency diseases. So as you can see, there are countries with lower income having much higher rates of emergency disease burden than those with a higher income. And Pakistan is there. It's kind of difficult to see sometimes with so many countries, but just wanted to highlight that. We also know what determines patient's outcome in the emergency department. And I'm going to show you a couple of slides highlighting that. So first of all, the expertise of the person who's providing care. And we all know that, and that's the whole point of having so much long training and all that. We also know the time is an important determinant of the outcomes. And finally, the information that people have who are providing care makes a big difference. Now, the expertise, time, information, let's try and explore that a little bit more. When we talk about expertise today, we have been very successful in introducing the emergency medicine training in Pakistan. I'm not sure the most recent numbers, but Pakistan is producing maybe 10, 12 emergency physicians, FCPS a year, maybe more or less. And the need is about 30,000 if you apply these standards that developed countries have. So if you're producing 10 or 20 a year, just imagine how long will it take for you to fulfill that need. And then the question is, and that's what Dr. Ghazanfar asked me was, how do we improve the clinical decision by our frontline providers who may have limited experience in training? And how do we make sure that right decisions are made all the time? And that is really not possible without thinking outside the box and innovation. The second piece is, as I mentioned, information. And how do you give the frontliners information for decision and give them only the useful information and take away the useless information? So no more, no less, all the time. How do you make that possible? You know, some hospitals in Pakistan have electronic health record. They may have more capability of giving that information. Others may not. How do you give that right information at the right time to the clinician? Again, that's a big question, even here in the US, let alone in other countries with limited resources. And the final piece is the time precision struggle, right? We are all in emergency medicine trying to fight the time and trying to provide the best possible, most precise care within that limited time. So how do we recognize patients with potential health emergencies, diagnose them early, and provide effective treatment for that specific individual within those times? So, you know, when we started training many years ago, there were very few conditions where time was that big of an issue. There was treatment for acute myocardial infarction, but since then, now we have, starting from signing EKGs and seeing that within 10 minutes, stroke, CT to time to CT, time to cath lab, time to antibiotics, of course, trauma care. All of that has become very time sensitive and time specific, which we know makes a big difference to the patient's outcome. Let's move on to the trends in medicine now. What is happening? There is today more data than ever. There's greater pressure of time. And unfortunately, all of that is happening with the fixed analytical power of human brain. Human brain has not really kept up with the pressure that we have today. We have too much knowledge. We have limited ability of human brain. And we have higher expectations. There's also more and more complexity in how and where we work. This was a very interesting study recently conducted in Rwanda. They were looking at the trauma care system. And they did a qualitative study asking people to to identify reasons for delays at various levels, delays seeking care, delays in transportation, delays in the care at the hospital, and then staying with that care and a delay with that. And this diagram, I'm not saying you should read, understand, and remember this. The point is, this is really a complex system you work in. Also, when you look at the errors, the problems that we all face when you're working in the emergency department, that's been now fairly well understood. There's a lot of science behind it, but you can see the decision makings that we do and the errors that we can make involve so many things, starting from how the ED is designed, the overcrowding, of course, the fatigue, the teamwork, transitions of care, patients who are not owned by anybody. All of these things are there, and then of course the radiology lab and other things that we work with. And that has led to a big pressure and movement. This is data from the US, where medical error is recognized as the third leading cause of death after heart disease and cancer. And we all keep hearing about that. And I'm sure the numbers are similar in a country like Pakistan. And this slide again shows more specific to emergency medicine, and in this case, pediatric emergency medicine, the causes of error, fatigue, burnout, distractions. How many times do you get distracted, interrupted when you are trying to think about a patient? And then, of course, the communication issues and all of that. We all pretty familiar with that. So there are issues in terms of how complex system is. We work in an environment where the errors are more likely to happen in many of the places. At the same time, we have seen a significant growth in computing power. Computing power is the pace of technological change. As you can see on this slide, it is changing exponentially. In 1900s, you had very limited computing power. Very recently, the computing power has not only taken over individuals, but also, as you can see on the right hand of the slide, it's the group a computer can actually perform at a much larger, almost 1,000 people calculation. As a $1,000 laptop, and this was a few years old slide. I'm sure the numbers are much higher now. And as the technology is changing, before we can completely make the use of previous technology, emerging technologies, new technologies come in, and so computing power, the growth of technology, and the growth of data. This slide is on a logarithmic scale showing the volume of data in a single year. And this is, again, many years ago, Facebook was creating 10 raised to the power 11 or more volume of data every year. And as you can see, the hospital electronic health record is doing not too far. I mean, again, it's a logarithmic scale, so the differences are much bigger than what you can see on the slide. But we are producing immense amount of data from the health system. We also have a better understanding of the issues. We think that we need to provide patients care which is more specific to that patient, because we know that some people survive and others die with the same diagnosis and same treatment. Why is it that some, the survival in some patients, some people survive cardiac arrest and others don't? Why is it that some people respond better to certain pain management after trauma than others? Why is it that some people tend to respond to treatments such as steroids after sepsis? We have realized that our decision is imprecise. We have traditionally taken a very singular approach because of the issues with limitation over brain power and have not considered larger issues, um, and that has brought not only the patient issues but also more social, economic, environmental profile, and all of these have really limited the practice of emergency medicine, what we can do today. And I'm going to give you an example. Triage, for example, 70% of patients are triage in this category 3 if you use ESI or similar. What does it mean? 70% of patients is not really precise information. We've also learned a lot more about our decision making. We are making two types of decision: intuitive, fast, autonomous, which we are pretty good at, but we make a lot of errors, and then slow and deliberate, which makes few errors, but often we don't have time for that. So with all of this background, I'd like to bring you to the solutions. And where are the solutions? What's happening? One common solution was, and we grew up with that, we're still teaching our students, is be better, be smart, or smarter. We ask questions like, give 30 differential diagnoses of right index finger clubbing, multitask, uh, and be strong. What doesn't kill you makes you strong. That is obviously a system that works for, in some cases, not all, and there's significant limitations. And as we know, the brain power limitation is what we are dealing with today with all the data we are facing. And I found this really interesting study where this group of researchers asked the medical students in Pakistan about their perceptions in preventing medical errors and patient safety. And as you can see on this table, when they were asked, and this was a pre and post intervention, so they had a workshop, and when they asked them if we improve an individual's attention or capacity, we can prevent medical errors. As you can see, most people agreed, and if you look at question number 9, item number 9, medical errors are caused by lack of individual capacity or attention. Almost 70-80% of students thought it was medical error was caused by lack of individual capacity or attention, and that I think is not a very good way of thinking. I feel that it is actually not, in today's world, not just the responsibility of the individual, but a much larger system level engagement that needs to happen to improve. So besides being a Superman, we have tried using simple technologies help, such as trauma care checklist, where you look at the checklist, you make sure you're not missing anything. That is being used in many places. We've heard about clinical decision rule. This gentleman, Professor Ian Steele, introduced many of those. We've heard about Ottawa knee rule, Ottawa ankle rule, Ottawa syncope rule. They used simple logistic regression or regression analysis to come up with rules that will help predict patients with the ankle fracture, for example, or those who have cardiac causes of syncope. So there was the other thing that people used and are using to make the decision. In my practice, I'm sure in yours, for pulmonary embolism, Well's criteria, or for coronary artery disease, the heart score is used multiple times in a day. Now let's go to the clinical decision support. That's a little more higher level, where these are the platforms that combine multiple clinical data inputs to produce a single output, which can be diagnosis, advice, risk stratification, so that clinicians are helped with difficult decision making. And where I practice, I often get the support built into the system. It shows up when I'm making a decision on antibiotics, or ordering an imaging study, and that decision support will help me. And this slide really shows how this data management layer, which includes clinical data, has some knowledge built into this, and the patient data creates through an inference engine output that is available to the clinician, either through the electronic health record, through the mobile text notification, or mobile app. Just to give you an example, systematic review was conducted for acute coronary syndrome in the pre-hospital setting, and they looked at multiple of these clinical decision support systems, and they compared the sensitivity, specificity, positive predictive value, and negative predictive value. And as you can see, and there was a lot of heterogeneity, there was a lot of differences in these studies, so there's limitation of that. But as you can see, as the negative predictive value, which is like the question you have is, this patient does not have acute coronary syndrome. That's the answer you're interested in. Negative predictive value of 86%. If you have machine reading the ECG, if you add to that the history, then you increase it to 96, almost 97%. And if you add biomarker to the machine, it will start to give you almost 100% results. Of course, the data, the p-values here are one could debate that because of the sample size. And then from the clinical decision support, we go into the big data, artificial intelligence, machine learning. We keep thinking about it, hearing about it, right? But what is artificial intelligence? It's the capacity given by humans to machines to memorize, learn from experience, importantly, to think and create, to speak, to judge, and to make decisions. Now, it used to be pie in the sky thinking, but it's happening now. And this diagram just brings everything together in terms of the terms that you use. On your left, left, you see the data science, the big bucket term, and it includes the scientific methods, algorithms, systems, etc. Then you go into data analysis, which allows you to look at modeling data, process inspecting, cleaning, and transforming data. Then you go into analytics, which is actually creating meaningful patterns out of data. And there are physicians, as you may know, are doing their fellowships in analytics now. And then from those analytics, actually mining the data that is going to be useful for decision making on a patient. And all of this coming from big data at the base of it. And big data is, broadly defined as data large enough that cannot be analyzed using your regular your regular processing power of the computer. So this data science, analysis, analytics, and data mining then informs your artificial intelligence, which is again a big bucket term. And there are some examples here of where the AI is being used into more specific machine learning, where it learns from the data of artificial intelligence and does a little more complex work for you. And then deep learning, which are actually self-learning systems where the patterns are recognized and they learn their own learning the patterns, and they start to get better with time. Something that really these machines can learn things so quickly because of deep learning. What would take years for humans to learn, they can learn in minutes to hours. So how do we apply all of this in emergency medicine or medicine? I'll give you an example. This study published recently, and they looked at predicting hospital admissions and emergency department triage using machine learning. And what they did was they went to a couple of emergency departments. They looked at the triage data, and they add more data to the triage data, patient information, and labs. and saw how good is that machine in predicting the decision to admit. So you can see on this table the demographics, triage evaluation, chief complaints, and then getting a little more history, past medical history, medications, vital signs, etc. And then in the final column, you have all of the variables. And the total variables that were fed into the system was 972. We as human brain really cannot analyze 972 variables at the same time. And what did they find? When they applied logistic regression versus the machine learning and then finally the deep neural network, they found that when we fed this full information to the machine was 90+% accurate. The area under the curve was more than 90% in terms of decision, the right decision to admit uh, to a reasonable degree. I think this was something that essentially support, if not replace, the decision maker in the emergency department. And the question that I asked initially is, how do we improve the decision making? Here you have an example where you have a lot of variables being fed into the system. The system can make the decision. So in this study, the conclusion was machine learning can robustly predict hospital admissions using triage information in patient history. The addition of historical information improves predictive performance significantly compared to using triage information alone, highlighting the need to incorporate this variable into prediction models. The more data you have, the better prediction you have. This is another study that looked at triage, and they looked at machine learning and compared machine learning triage with the emergency severity index. Was done at Hopkins by my colleagues there. And what they found out was that when they were looking at ESI scale 3, and I mentioned that a few minutes ago, so sort of a waste basket, 70% of patients are in that group. They said that we applied electronic triage to ESI level 3 patients, and they looked at when there was an agreement, when the electronic triage system said we need to triage them up, like this electronic system thought they were sicker, or down triage, and then the systems thought that patient is not sick enough. And as you can see, the predicted outcomes, when the electronic triage said that we need to up triage, the critical care needs for these patients increased quite significantly compared to when they said down triage was almost 0%. Also, the need for emergency procedures was much higher. The rate of hospitalizations for patients who were up triaged by the system, electronic system, was much higher than what was ESI would have predicted. And when you look at the secondary outcome, just using labs, lactate and troponin, you can see that the electron triage did better than when there was just regular triage at ESI 3. So this is, again, another example of where the world is moving and how the data is driving decision better than what we have traditionally done. Now, all of this is not without limitations. When we get a lot of this data fed into the clinicians, there is an alert fatigue. We also worried about the negative impact on skills of the providers or physicians in this case. The cost of implementing these systems, similarly costs system and maintenance challenges. There's also a sense of distrust amongst user of the technology, and especially among healthcare providers against this, because they can't completely understand how these decisions are coming through, because a lot of this is in the machine, kind of opaque to us. There are issues with transportability and interoperability. There are issues with some of us are not very computer literate, and that is a limitation for people who don't feel very comfortable with it. There's also an issue of garbage in, garbage out. if you have put in inaccurate or poor quality data and documentation, you'll get wrong results. Also, I want to emphasize that what the disease distribution and prevalence and resources make a big difference. What works in Baltimore or New York where I work may not work in Karachi because of differences in the kind of patients we see and the prevalence of diseases. Finally, it changes workflow, and we are not very, sometimes we are not very comfortable with it. So these are the limitations of using technology. I'll just finish my talk with these concluding thoughts. Medicine is changing. Uh, Machines backed by big data will play an increasingly significant role, and I think they're playing a role today. Our infrastructure and our medical education system has to be ready for that change. Um, Artificial intelligence, machine learning, precision medicine would help healthcare workers provide better decision making, provide better decision maker, provided local data is available. And I hope that with the technology, the differences in the quality of care will reduce, and there is what I call more democratization of medicine. I'll stop here and thank you so much for listening.
Talk. So without further ado, let's now move on to our Q&A session and discussion with the honorable panel. This session will be chaired by Dr. Junaid Razzak, and we will be accompanied by our speakers, Dr. Bilal Usmani, Dr. Benjamin Abella, and Dr. Basit Sheikh. Dr. Junaid will be chair for this session. So I hope all of you can hear me, and yes, we are all online. So let me just start with the first question towards the panel. How artificial intelligence is applicable to extremely low resource settings that lack even basic health facilities? So this is a question towards the panel. If anyone would like to say something about that.
Adil, can I try?
Yes, sir, please.
So I think, first of all, thank you for the opportunity, and good to see Dr. Professor Abella early in the morning. I think the impact of artificial intelligence and its relevance is much more to the low resource setting, frankly, than high resource, because the difference you can make is so much bigger. It is, the technology is not difficult, it's just getting the right information. And I think if we do that, we can make very significant change in the quality of care we provide and outcomes we have.
I'd like to make a point here. I think technology and low resource, that parallel doesn't work anymore. Okay, where Benjamin is obviously a developed country, so it's never mattered there. But I think mine, and I'm sure Bilal would Dr. Bilal may concur with this, that even within the settings of Pakistan now, the basic technologies required to deliver AI are available en masse now. And as I emphasized in my talk, I think the important point is to find a strategy that leverages whatever technology exists within these low resource environments, with a view to providing that AI-based solution. And I think it's perfectly possible if we can chart a map out.
All right, thank you. So the second question is, what hurdles are commonly faced when implementing AI in clinical situations? And as an extension of that, there's another question that how fruitful is implementing AI based on developed world data useful in implementing in areas where data is scarce?
Okay, my experience has been we try to do the use of X-ray texture analysis, using the X-ray texture analysis and comparing that to hip fracture probabilities. And so the idea was to take a whole range of X-rays, do an image processing on that, extract all the necessary textures from that, and then for each patient, then correlate obviously whether they had a hip fracture or not, after the hip fracture, what had happened, and so on and so forth. And what it led us to believe is clearly that you have to work with data with the environment in which you're working in. Okay, obviously specifically for hip structures and hip fractures, um, the Asian subcontinent bone structures and strength will be different to Asia Pacific bone structures and different to North Atlantic sort of in America. So I'm reasonably sure that localized data is dead important to get the right diagnosis. But and this is my important point. From an organizational perspective, it becomes an obstacle to say, well, we don't have the data. And therefore, if we don't have the data, how are we going to go ahead with this type of analysis and diagnosis? And I would put a caveat here that we don't want the absence of data to restrict this type of activity occurring. So those are the perspectives that I'd place here.
Yeah, I would like to add a point to that. So sometimes, we as Dr. Abdul Basit said rightly, that sometimes we need to look at some another place for data, and then there might be some another thing or another physical or demographic or something more of a behavior or environmental thing that is correlated, that is somehow acts as a proxy variable to that. It's always good to look at more than one source and then see how it's impacting. So when we didn't have data, we use the so for the daily, I don't know the length of stay for a COVID patient at the very beginning, so I use from different countries, and then the detection rate, we don't know how many of the detected cases are true as compared, so how many of the people are detected for COVID infection or hospitalized versus how many are actually or in the public, in the community. So we sometimes need to think at different things to look. So interestingly, mobility patterns is a quite a good indicator, as I found, for spread, and as for hospitalization and for critical care. Yeah, so we can do these sort of things. Just try to think outside the box, and we might get something rather than not doing any analysis.
I'm just going to add your second point. In emergency medicine in Pakistan, and having spent many years trying to figure out the data on emergency care in Pakistan, it is a problem. It is a challenge, and some of us who are over enthusiastic, who want to do things, if we put in data which is not accurate or does not capture the reality, it will lead us to something which is not true. So, as we discuss, machines, are extremely dependent on what we put in. So one of the things we need to do better, and it might come up later on, is how do we capture that information in the acute care setting? Radiology and pathology are there; they're easy to be followed up afterwards. But emergency patients leave, and they leave with their paperwork, often in many settings. So that is a big challenge that we need to think about. I think Ghazanfar from Indus, Dr. Ghazanfar from Indus, has been trying to do that. A few other people have done it. So that's a big challenge that we need to figure out.
Yes, thank you. Thank you, Dr. Junaid, Dr. Bilal, and Dr. Abdul Basit. The third question that we have is related to pre-hospital setting. How AI can be used to guide patients to seek help from appropriate facility rather than going doctor shopping or hospital shopping.
So, sorry, let me know if I'm speaking too much, but when I used to work in Pakistan, one of the most common reason for me to get a call was not, what do I do? Not from other physicians trying to figure out how to treat a patient, but it's often from family and friends on which hospital to go to and what doctor to see. And I'm sure those other people are the same thing. Uh, the healthcare system is so complex from the common man's perspective that it is impossible for them to navigate or don't feel comfortable navigating it. Now, if the question is, if I have an emergency today, if I'm having chest pain, which hospital should I go to? There should be a relatively simple question to answer. It does not require AI. It just requires clarity on the system and somebody to regulate that system. I think, where are the chest pain centers? Where is the ICU bed available? How busy are the emergency department? That information has been being used in many other places without the use of AI. So I think sometimes we try and make some problems too complicated. This is a relatively simple problem that can be answered. Uh, and then there are more complex issues that obviously require AI, but this is not the one where I think there is a need to do a little more complex analysis.
If I might add, hopefully you can all hear me, and it's a real pleasure to be with all of you in Pakistan. Thanks for the invitation. I would agree with those points. And in the United States, there's some efforts underway to improve pre-hospital decision-making and allocation that don't involve AI, but there are these companies that have medical direction and systems where patients can be referred instead to clinics as opposed to going to the hospital. And these are very human things and not AI things. What it requires is access. You have to have access to the information. So for example, if you're going to have a group of clinicians plug into a emergency call to say, instead of going to the hospital, why don't we get you an appointment tomorrow? That's all well and good, but you have to have access to those clinics, to their scheduling and so forth. So it may be less a question of AI and automation and more a question of access and fluidity in the system, which is sort of extending Dr. Razzak's points there, that it's really a human problem and a connectivity problem.
All right. Thank you, Dr. Junaid and Dr. Benjamin. Next question is to Dr. Abella. As you mentioned, data entry is voluntary or mandatory. How can we promote voluntary data entry in registries?
Yeah, it's an excellent question. And for those who may not understand the context of that question, I talked about the CARES registry in the United States, which is a voluntary cardiac arrest pre-hospital registry. And with voluntary registries, of course, you have this challenge of, well, someone has to, of their own free will, want to put in this information. Why would they do this? What are the incentives? And, monetary incentives, of course, become very problematic for all sorts of reasons, one of which, of course, being just the enormous expense of it. So how do you motivate? Well, I would make two important points. One being that when you have a registry that involves many hospitals or EMS systems, multiple groups, there's a very important human motivation, which is you want to keep up with your colleagues. So making a system when it's voluntary, one where there's transparency on who's involved and who isn't. You want to be on that list of people who are involved. In the United States, we have an idiom, a phrase called keeping up with the Joneses, meaning if your neighbor has the new TV, you want to have the new TV. If the neighbor has a nicely mowed, beautiful lawn, you want to have a nicely mowed, beautiful lawn. And so if a registry says, well, these 8 hospitals are participating, Hospital 9 isn't. Why is that? There's sort of a motivation there. So that helps. Call it friendly competition, if you will. The second competitive nudge that can be helpful is at the level of individual hospitals that are participating. How do you get them to put in more cases? How do you get them to be more engaged? And again, transparency and dashboards are helpful. This is done all the time in clinical trials, where clinical trials to motivate sites to stay involved and be more aggressive about screening and enrollment will often have a a leaderboard, we might call it, a list of sites, who's performing the best, who's next best, who's, and then sort of send congratulations to Hospital X. You've enrolled 6 patients this week. That's terrific. And by making these public, we all like accolades from colleagues. We all like to look good. And so that's a free technique that registries and clinical trials often use to nudge people and motivate people. So, and both are under the theme of really transparency. These are not perfect solutions, but they're helpful. So there's probably other techniques as well, but those are the 2 most readily accessible techniques, I would say.
Thank you, Dr. Abella. Our next question is to Dr. Junaid. When developing registries, how can we overcome the hurdles of data sharing?
Just taking Dr. Professor Bella's comment on CARES registries, which is the cardiac arrest registry in the US. New York, for example, does not share the data. It's interesting, right? There are political reasons. There are other reasons which may not be visible or heard. There are some settings where you're required to share data. There is a commitment from wherever the political or the medical leadership is, and they say, we'd like to share this information so we learn from each other. And there are others where you can't and you don't want to. In the context of Pakistan, I think it's going to be a combination of the two, working with people to make them see what is it that they are going to get out of it. Why should a hospital share their data, and what is in it for them if their systems are improving? And the other concern is I don't want to look bad compared to others. People are working very, very hard, and they don't want to be seen as not working hard enough. And making sure that people see what they are getting. Number 2, making sure that that data is confidential. It's not shared without people's consent. And I think putting in time and effort, it just takes a lot of time to bring people together on registries. So those are, my very early thoughts.
Could I make a point here? I've had an extensive relationship with Indus Hospital. So I worked with Dr. Amin Chinoy and Dr. Mansoor Ali Khan from the orthopedic departments, and that was my actual introduction within Indus Hospital. And then we discussed setting up a hip registry, very much like what the European nations have set up. And just I'll present the essence of my extraction from those discussions was that there's a Royal Society of Orthopedics and so on and so forth. There's all these societies that exist in Pakistan, and I think it's very important to promote the need to have data sharing. Okay, when the imperative of data sharing is understood, then those medical practitioners will then themselves find a way through those political problems, because they will realize that the imperative of data sharing overrides those political issues. I'm sure the political issues will remain. I don't doubt that. But I think that for a society like Pakistan, which is still primitive in terms of its data sharing activities, it's back down to the essence of our session today, which is that AI can deliver so much to society, where our society needs it more than maybe the Western societies, and without demeaning them at all in any way whatsoever. If we can create that imperative, then the medical practitioners themselves will then, through their own associations, their own societies, will then begin to navigate through those political issues.
Thank you, Dr. Basit. I think we'll take one last question now. This question is to the panel. How well is implementing AI received on the part of the stakeholders, being hospital and practitioners, and what can we do to improve in that aspect?
I should probably start off with that. I think from a patient perspective, I don't see any obstacles. I've not sensed any obstacles because by and large, what their importance is for them, the important point is the quality of medical care delivered to them. And as I mentioned in my presentation, that as long as the patient is actually dealing with a human being sitting in front of him, talking to him, and he's talking through a tab, the patient isn't going to be worried. And obviously, patient security and data security are an imperative, no question about that. I think the other side, the organizational side, has lots of challenges. Let's put it in that term. And by and large, being organizations who have to run these organizations on a day-on-day basis, on a week-on-week, they have to balance budgets, they have to balance other things. It's not easy to adopt new technology like this. And it's not easy to adopt new technology which seems to have shown its success in the West. Okay, so there is that issue of that adoption. And so all the efforts done by the researchers in Pakistan, and I have to mention Dr. Ghazanfar in terms of the efforts that he's making with the emergency department. It's impressive. It's through these efforts that, as long as they are highlighted right up to the organization, I mean, right up to the CEO level, if they are not highlighted to that level, then the adoption of these techniques will remain limited. So I think it's very, very important to open up that organizational mindset.
Dr. Bilal, your thoughts on this part?
The concern is that so AI can do two things. One, it can assist the decision making, and I think we are okay with that. People are comfortable with that. What people are not comfortable is replacement of the decision making completely. So I think a lot of concern comes from the fact that the physicians and nurses and everybody else will become jobless, and the hospitals will not be required, and so on and so forth. And there will be some activities we do which adds no value, and I think that needs to go away. But largely, what we do still has to be there, and replacement should not be the concern. It is how do we assist the clinician in making the right decision using AI.
Could I just ask, maybe Benjamin can add to this? How many medical practitioners' jobs have actually been replaced by AI in where you work and wider?
It's a very good question. I appreciate it. From my vantage point, it's a little hard to quantify. So I'll be the first to admit when I can't give an excellent answer. But I would say this. I think not as many as the fears. My sense currently, again, just my sense working in a large health system, is that AI at this juncture has largely helped, supported, in some cases improved efficiency, in some cases maybe less so, but it hasn't so much as replaced people yet. Now, might it in the future? Maybe, but I do agree with Junaid on this, that I think in many cases there's enough fear and concern about not having a human involved at some level that it will often be seen as an adjunct. Now, I do think in some fields where the human touch or human interpretation of complex emotional or communicative things are less important, there's more of a risk. So I think in radiology, for example, I mentioned that in my talk, I'm not a radiologist, I don't know the field very well, but certainly in talking to radiologists, it's image interpretation. Now, interventional radiology, very different. But if it's just looking at an image and rendering an interpretation where there isn't a subtlety of a human interaction and emotional content and cultural perspectives and presentations and so forth, one might imagine more of a risk of replacement of some amount of humans. But again, I don't think that's happened yet, but I do think in the next 10 years, that's going to be a substantial risk in some fields. In emergency medicine in the US and in Pakistan, the ability to integrate enormous streams of human emotional content, right? I mean, when someone comes to me and says, I have chest pain, well, what is their motivation of saying that? Are they here because they want to be there? Are there other issues that are maybe more important? These are subtle, and an emergency practitioner has to interpret them very quickly, make decisions quickly. It strikes me that that's a harder AI challenge, and it may be longer or maybe never will it be replacing humans. Maybe. Those are some thoughts.